and I invite Professor Andrew Davies to give his talk, and then we will discuss.
Thank you very much, Vakili. So you Swiss, you like order, you like trains that arrive on time, and you like to be organised. In the UK, we're somewhat more prone to chaos, and we don't like to be restricted by guidelines. We're kind of free spirits. So rather grudgingly, we wrote some guidelines, but actually haven't bothered to update them since 2011. So you know, we are increasingly seriously being looking at guidelines and being able to define pathways much more. And of course, we have the ESMO guidelines, and Robert Marcus, who was a member of the working group, and so really the views that are in the ESMO guidelines are very much the same views as they are from the UK. And so basically, our recommendations from the UK are just the same as the ESMO guidelines and just the same as the Institute of Southern Switzerland. And so we're all happy and we're all friends. So, just to remind you, follicular lymphoma, this is old data from St Bartholomew's Hospital. It's data of patients treated with chlorambucil and repeatedly treated with chlorambucil. But the central dogma that we see from this graph, that remission duration becomes shorter, particularly after the second duration, and also the response rates to chemotherapy declines, so that you get a patient that becomes increasingly refractory to chemotherapy. And I think that's a really important thing to remember in this context of us having a whole new range of different therapies and trying to turn around the whole of this way we approach the management of follicular lymphoma. So in terms of our guidelines from the UK, there's a strong focus on getting the diagnosis right and a strong focus on regional teams and regional referral of all hematopathology to specialist areas. So there are a smaller number of specialist groups of hematopathologists centred around the country that are looking at all malignant lymphomas and other types of hematological malignancies. There's also a strong recommendation for formation of multidisciplinary teams, and that we meet as a region in a hub-and-spoke mechanism on a weekly basis to discuss all the cases, and that we also biopsy, and rebiopsy. And there's an issue here, because when we don't look at central review of pathology, that we do get discordance. And even in something like follicular lymphoma, where actually you can hold the microscope slide up to the window and see that it's follicular lymphoma without even using a microscope, there is still a problem with discordance between local pathologists and central regional review. And just in this study that came from a group in London, the change in practice of moving into more and more cases into a central review was associated with a clear improvement in their discordance rate, but actually with a huge number of cases of follicular lymphoma, the discordant rate between the local pathologist and the expert hematopathologist was still 23%, including non-malignant diagnoses in there. Okay, so this framework of being able to work in a hub-and-spoke mechanism actually serves the UK very well. So the first thing our recommendation is faces the issue of early stage disease, and it doesn't really address the issue of watching and waiting in patients who had full surgical excision of biopsies, but goes really into recommending involved field radiotherapy of 24 Gray given in 12 fractions, and that's given with a high level of recommendation. Now, in the UK, what we did do and published this year was to do a study looking at reducing the dose of radiotherapy. This is because there have been numerous reports that a lower dose of radiotherapy was equally as effective as the 24 Gray that we are all very used to. So this was a study for all indolent lymphomas and looked at randomization per site that you were going to irradiate rather than patient numbers. There was clearly less toxicity with the 4-gray arm, but the response rates and the complete response rates with patients treated with 4-gray was less than those who received 24-gray, and that the progression-free survival per site was also inferior. And indeed, this study closed to treat patients that we were going to treat with curative intent early before actually all the other sites were completed. So it remains that 24-gray in 12 fraction remains the standard of care. So what about patients with low tumour burden disease who are asymptomatic? Well, we've seen this graph already tonight. This is from Kirat Ardeshna's study that looked at patients who met the criteria for advanced stage but low tumour burden, and then we see that there was no improvement in overall survival between observation and the use of chlorambucil. And I think it's really important to stress from this data that actually 20% of the patients 10 years from diagnosis were free of the need for therapy. Okay? So expectant management in the asymptomatic individual remains the standard of care. Now, we've already alluded to the British study of the watch and wait study. Now that we have got a less toxic treatment with rituximab, that actually, can we shift that dogma that you need to sit tight and do nothing and wait for something to happen with the watch and wait study? So patients were randomized between observation and they were randomized between our monotherapy just given for 4 consecutive weeks or our monotherapy given followed by maintenance. And actually the single 4-week course of treatment with that arm was closed as it became increasing interest in the use of maintenance rituximab. So that arm was closed, and I think probably sadly, actually, and it would have been very nice just to have seen what happened to those with 4 single administrations of rituximab. And as we've seen tonight, the blue line represents those patients who are being managed on an expectant basis, and they behaved exactly as one would have expected, with a median time to initiation of therapy of about 30 months. And both the patients who received just induction rituximab and those patients who received induction and maintenance, we can see that the time to next treatment was longer, or new initiation of treatment was longer, and approximately the same. And that was associated with no difference in overall survival, and importantly, there was no difference in the risk of transformation. So, in the UK, are we all giving everybody who comes in clutching their tabloid newspaper rituximab induction who are asymptomatic? And the answer to that is no. I think the key thing about this is that we need to have a clear discussion with the patient at the beginning of their treatment journey so that they understand why we are doing this and what our strategy is for the lifetime or the clinical course of their disease. So although we did this study, this is not something that we've been adopting in the UK. So what about immunochemotherapy in those patients with high tumour burden disease? So the guidelines from ESMO, obviously the choices are CHOP, RCVP, BR, etc., and including rituximab monotherapy. The wording of our UK guidelines is that you can use rituximab in combination with chemotherapy, but gives no guidance at all as to what that would be. Okay? We have been in love in the UK with RCVP for very many years, and RCVP has very many advantages. It's a very minimal toxic regimen. It reserves your anthracycline until the time that you really need it, when your disease transforms. But along came the Follow-5 study, and somewhat knocked us a little bit out of the water. And of course, we've seen tonight that we can achieve better response rates with a more intensive CHOP-based therapy or fludarabine and mitoxantrone, and that the progression-free survival of RCVP was much less than the more intensive regimens. But I think what's really clear is that at the time of reporting there was no evidence of overall survival benefit, and we've seen time and time again in randomized studies that look at follicular lymphoma that a progression-free survival advantage does not translate into an overall survival advantage. Okay? So RCVP is not dead and buried, it's just gone a little bit quieter. So, This leads us to what are we doing most in the UK? And probably what we are doing most in the UK is giving rituximab and bendamustine as our frontline therapy based upon the results of the STILL study. You must remember that the STILL study was a non-inferiority design. So whilst you can see that the red R-bendamustine curve looks much better than the R-CHOP curve, it was not powered for superiority. So we can say at least bendamustine is as good as R-CHOP, but I think be cautious about the words saying that it's better. Okay? I'm also cautious that in the STILL study there was only grade 1 and grade 2 follicular lymphoma included and nothing about grade 3, and I particularly support your views on the grading as we discussed earlier in terms of the Swiss guidelines. The results of the STILL study were really confirmed by the BRIGHT study, which was powered for overall response rates and CR rates and showed that there was similarity between the two. However, one thing that we do think about when we look at the STILL study is we look at the behavior of the R-CHOP arm in the STILL study. So that's the blue line on the curve of the STILL study, and we can see that we compare that, which you should never do, with the R-CHOP arm from the Follow 5 study, and we can see that the R-CHOP arm did less well than on other studies. So there's just a little bit of caution in terms of the interpretation. Of course, the use of bendamustine, which we can now use through our Cancer Drugs Fund, was associated with a different pattern of hematological toxicity and a different pattern of non-hematological toxicity, and clearly was associated with a better quality of life than having R-CHOP chemotherapy. So I certainly believe that the use of rituximab and bendamustine for patients with grade 1 and grade 2 follicular lymphoma is absolutely the right approach. Single-agent rituximab, absolutely an old friend, high response rates in patients and certainly very durable remissions, as we can see from Michele's study. We actually don't use a lot of single-agent rituximab in the UK, either in the frontline setting or in the relapse setting. I think there's an ethos that actually if somebody has a clear indication for treatment, we should give them a treatment that's associated with a high CR rate and a very durable response. But we can perhaps talk about that as we discuss this. What about maintenance? So a strong recommendation from our guidelines about rituximab maintenance because of this progression-free survival advantage. And that is endorsed by the National Institute for Clinical Excellence, NICE, who actually don't have a lot to say about hematological malignancies because it's all slightly too complicated and there's not enough good comparator arms for their health models. So anyway, they were very definitive that actually we should be giving maintenance rituximab. And I like the words in the ESMO guidelines because the ESMO guidelines are much more considered, and they say consider maintenance rituximab for up to 2 years. And we know from the PRIMA study that was a 0.55 hazard ratio on the maintenance arm compared with observation alone, but clearly overall survival has not changed. So nobody is alive today because of maintenance rituximab. So I think we need to remember that before we get all too carried away with the widespread application of it. But everybody benefited in terms of progression-free survival, but there's a risk of infections associated with it, and we know particularly upper respiratory tract infections can be a problem for these patients. So I think you need to think very carefully about the use of maintenance rituximab, and we also can see some clear benefits, no difference in terms of quality of life differences. So on the basis of the Sabrina study, which looked at subcutaneous rituximab given in combination with chemotherapy, followed by maintenance rituximab, either with subcutaneous rituximab or intravenous rituximab, this study demonstrated that there was no difference in the pharmacokinetics, essentially little difference in the adverse event profile, and no difference in terms of the overall response and CR rates with a switch in formulation to the subcutaneous rituximab. So in the NHS, there's been pretty widespread adoption of subcutaneous rituximab in the maintenance setting. And that's absolutely fantastic for patients because they can come in, and if you're on fire, they can come in, have their rituximab, and go within about an hour because the administration is only just 6 minutes. I think what we should be doing is I think we should be being more smart or smarter about how we use maintenance rituximab, and we can see from the PET data from the PRIMA study that we can identify patients who are PET positive at the end of induction therapy who are going to do less well than patients who are PET negative. And therefore, we need to think about how we can use new agents, and we need to think about how we can use maintenance, because probably everybody doesn't need to have maintenance rituximab. What about grade 3 disease? So our recommendations are very clear that patients with grade 3B follicular lymphoma should receive anthracycline-based chemotherapy and be treated as if they had diffuse large B-cell lymphoma. I will remind you that grade 3B disease is a small subset, 5% or less of all the follicular lymphomas, and it's comprised of solid sheets of central blasts within your follicles. And the pathologists are getting better at doing this, but I certainly would recommend, if your reports comes out saying grade 3 follicular lymphoma, that you need to push them as it's whether 3A or 3B. 3B has very different biology. The pattern of oncogenic aberrations, the gene expression profile are different from grade 1 and grade 2 and perhaps grade 3A follicular lymphoma. So the data from British Columbia suggested that actually there was no difference in adding anthracyclines to patients with grade 3B follicular lymphoma, but they had a relatively small number of patients, just 22, in their grade 3B subset. And as we've seen already, the very extensive collection from the Nordic group of patients with follicular lymphoma who have been regraded according to the WHO classification, we can see that grade 3B patients actually do very well, and actually we can document a plateau on their survival curve. And if we drill in much further, we can see that those patients with grade 3B follicular lymphoma who do not have anthracycline have a very poor outcome, whilst those patients with grade 3B, who are treated with an anthracycline-containing regimen, have a plateau on their survival curve and absolutely look like the behavior of diffuse large B-cell lymphoma. So absolutely no doubt in the agreement there. So what about relapse disease? Well, we've already discussed some of the options that there are for relapse disease, and I'm going to say to you that the autologous transplant still has a very clear role in the management of relapse disease in the era of rituximab and all these discussions and novel agents that we have. So this is data from the BARTS and the Dana-Farber series that was published some years ago, and this shows patient remission duration for patients who underwent a CyTBI autologous transplant over a period of about 20 years. And we can see there's a clear plateau on that remission duration curve. So that's pretty impressive data. Of course, there was a risk of myelodysplasia with the use of TBI, and we could see from this study that patients who were in second remission benefited much better than patients who were in third remission. But we can get the same results rather than having to use a TBI-based approach by using a chemotherapy-based approach. So I absolutely think that there's a clear role for the autologous transplant in consolidation of second remission, particularly those patients who've had short remission durations. In terms of the allograft, well, I think the allograft is beginning to find its place. We can see some very good overall survivals and progression-free survivals with the RIC allograft, but there is absolutely a problem with transplant-related mortality still and the morbidity of graft versus host disease. Okay, so very briefly, because I want to have us to have some time to have some discussion. What about this plethora of new agents that we have to look at? Well, I think the thing is that we've got lenalidomide and we've got the R-squared regimen, which is generating some very impressive response rates. So in follicular lymphoma in the frontline setting, there was an overall response rate of 98% and a CR rate of 87%. So it's going to be interesting to see what happens, because the Relevance trial has put R-squared directly against R chemotherapy in the frontline setting. So I think it's going to be really fascinating to see what happens with lenalidomide. We're all very excited about the immune checkpoint modifying agents. We've known for a long time that T cells have a very important role in follicular lymphoma, and we've recognized for some years that the T cell component of your follicular lymphoma drives potentially your prognosis. And so there's been some work published with pidolizumab, which is a PD-1 antibody in a small number of patients given in contact with rituximab, and we can see some very good response rates, a 70% overall response rates, and some very durable remissions. And then there's this whole raft of pathway inhibitors. We have a range of PI3 kinase inhibitors with different isoform selectivity. Of course, idelalisib, which is a delta-specific inhibitor, has been the leader in terms of the class. And in patients with follicular lymphoma that are both refractory to rituximab and refractory to alkylators, we can achieve a response rate of 56% in patients with follicular lymphoma in a really tough crowd. So idelalisib and the other novel agents haven't made it anywhere near our guidelines yet, but this is available for us in the UK should we select to use it. And very interestingly, that the progression-free survival curve of patients with idelalisib is longer than the progression-free survival curve of their previous therapy. So this is changing around that central dogma of progressive shortening of remissions. So idelalisib is being looked at in combination with chemotherapy, so rituximab and bendamustine in a study. And we have seen that a number of these other PI3 kinase agents have shown early activity in follicular lymphoma. So I think this is a complicated space, and we should watch this space. What about other agents that may affect B-cell receptor signaling? Well, we could see some early evidence of response of ibrutinib in the phase 1 study, so 6 out of 16 patients responded. There is data accumulating now on the use of ibrutinib in follicular lymphoma, and this study was presented at ASH from Nancy Bartlett, which was 40 patients demonstrating an overall response rate of 30%. So we don't know how this is going to shake out, but the quick look at that is that perhaps ibrutinib may not be as effective in the management of follicular lymphoma as perhaps the PI3 kinase inhibitors are. There's a lot of excitement about the BCL2 inhibitors, and there's been clear responses in the single-agent data with ABT199. We've got to work out how we're going to best put that together, and of course there's a whole range of new antibodies. Transformation remains a big clinical problem in the era of rituximab and immunochemotherapy. We haven't probably seen a reduction in the rate of transformation, but there's perhaps some signal from a number of studies that perhaps the use of rituximab and the use of anthracycline may be reducing our rates of transformation, but very much the jury is out. My clear message from this is, so although our guidelines are not up to date, what we are doing and what we are increasingly doing is trying to understand the biology of follicular lymphoma. I think we're some way behind in terms of the biomarkers of some of our other colleagues working in hematological malignancies, but I absolutely think that we're getting there. So for my mind, my money is on working out the biology, doing some excellent preclinical work, and then we can work out our unopened and open questions in follicular lymphoma. Thank you.